to invite Dr. Himanshu himself for a talk on dry eye in post-cataract surgery patients.
Well, meanwhile, let me steal some time and thank the organizers to have this wonderful session. It's very interesting that industry likes dry eye, and it's heartwarming that even the attendees like dry eye. Seeing so many people in the morning is quite heartwarming. So I am going to talk to you about perioperative dry eye related issue, especially with the cataract surgery. I do not have any financial disclosure here. Now, cataract surgery in dry eye, does it actually really exist? Interestingly, there are enough and more articles out there and studies out there which shows that yes, there is significant amount of cataract related dry eye which exists. The cataract disrupts the homeostasis of ocular surface and which leads to dry eye of various type, which can last for a few weeks to few months together. Perioperative consideration can also start from the age to the previous ocular surface disease, the intraoperative treatment. We will go for all these things later on one by one. So when we talk about dry eye and cataract, what are the preoperative consideration when we look at in these cases? We saw previous speakers speaking about the dry eye diagnostic tools. Well, important thing are these simple, humble tests, which are your clinical tests like fluorescence staining or surface staining and Shermer's test. To me, if you have to select only one test, well, that would be a fluorescent staining of the ocular surface. So apart from getting the surface stain, which gives you your ocular surface staining, your TFM breakup time, the fluorescent staining can also pick up those nocturnal leg ophthalmos or incomplete blink. And many times these cases, the cataract surgery may actually worsen the dry eye, but these cases may have pre-existing either incomplete blinks or nocturnal leg ophthalmos. Treating them preoperatively would certainly be an important thing. Why do we need to treat preoperatively these dry eye? Well, interestingly, we know that dry eye can actually affect the topography. In fact, blinking can affect topography, and we know that dry eye can sometimes affect the biometry also, especially when you are looking at cases where you are targeting cylinder using your toric IOLs, or you are going for a premium lenses like your multifocals. It's very important to make sure that ocular surface is stable. Sometimes the tests like gonioscopy or intraocular pressure measurement can actually alter your biometry and may give you a toricity which actually was not true. And treating them may actually change your cylindrical power. So before you go ahead with any of these things, make sure the ocular surface is stable. AIOCMT3 has given a nice algorithm based approach in preoperative assessment of these cases. The most important part here is very interestingly what they've given, which is LLPP, which means look. So it means look, lift, pull, and push. Look means look at the blink, look at the ocular surface, look at the lashes and everything. Lift means lift the lid, look at the things under the lid, look at superior limbic region. Pull means look at the laxity of the lid and how the lid position is. And push means look for the meibomian gland. It's very nice to remember LLPP. What it ultimately does, well, you look at the sign of damage of the ocular surface. If the sign of damage is not there, you surely can go ahead with the surgery. If you see the damage sign there, then you might as well treat that first. Ultimately, when you treat the ocular surface becomes normal, then you can go ahead and do the treatment. But if there is significant damage of ocular surface, please treat it first. Coming to the intraoperative factors, what are the intraoperative factors which can lead to ocular surface damage? Mind you, I'm not talking dry eye, I'm calling it ocular surface damage, because classical definition of dry eye, we have bound everything together in very simplistic way. But any of these things are part of ocular surface damage. So you can have repeated drops, irrigating solution, your povidone iodine solution, your anesthetic drop, many things whichever we use along with the phototoxicity and surgical trauma can lead to dry eye. Now these dry eye damage which occurs post-operatively may last for weeks to even months. Different studies show different things, but what it means that your individual patient may suffer for much longer than what you would wish it to be. Treatment wise, well, it's very important that the lubricant what we select should be good enough for the healing of the ocular surface, and sodium hyaluronate based lubricants do that thing and helps us in the healing the ocular surface. Sodium hyaluronate is something which may actually help not only the damaged ocular surface but to maintain the healthy ocular surface also. Anti-inflammatory like cyclosporin does help you to reduce the inflammation on the surface, reduce drug toxicity. Previous speakers spoke about the drug toxicity. If there is any meibomian gland dysfunction, needs to be treated in these cases, and some of these cases may actually benefit with punctum plug. Dietary supplement is on its own a wide topic, but if it works in your hand, you surely can go ahead. As you can see from one of these publication and many other publication and even lab studies what we have taken up showed that sodium hyaluronate based lubricant does help you to repair the ocular surface damage much faster. Coming to the MGD and dry eye, which many times goes unnoticed and undiagnosed preoperatively, most important part of this MGD in dry eye is to recognize the meibomian gland dysfunction or something called meibography. Now meibographer, there are plenty of meibographer out there in the market. Whatever you use, it's fine. These things, whatever you are doing is something which we are doing is quantitative meibography. Basically, you are quantitatively analyzing how much damage of meibomian gland has occurred and maybe classifying that. Does it mean that everybody needs meibographer? Well, I've been doing meibography for ages, much before even the meibographers were available. Well, simple thing, your autorefractometer can help. Just take the patient under autorefractometer or any other infrared device which actually gels with the reflection. Well, it may help. Even your security camera may help. So whatever you do, basically you want to make sure that you are looking for the meibomian gland. Why is it important? Well, it's important because till before the meibography came into picture, we all were told about meibomian gland dysfunction, that it's highly underdiagnosed and we must press the lid, look for the meibomian gland secretion. If it's not there, warm compressive lid massage. But when we got meibography and when we saw meibography and we saw the glands were normal, all those things, treatment would work. But when we see the glands are not there, even if you jump over the lid, nothing is going to come out. So doing those lid expressions like your meibomian gland expression things are not going to help you. Well, there are plenty of devices which are out there to help us to improve the meibomian gland flow, whether it's LipiFlow or simple humble device like MeibothermoFlow. Whatever you do, whatever works in your hand can be used. Remember that all these things are time bound. They do not have indefinite outcome. IPL or anything, any treatment, intense pulse light treatment like this thing can help you to reduce inflammation, but they have to be combined with meibomian gland expressors. There are many of these expressors out there. One which I love is Gauche meibomian gland dredging forceps. Very simple forceps which can be reutilized and re-autoclaved also, and works wonderfully well on upper lid and lower lid, whatever works in your hand. Expression of meibomian gland is very important. So to summarize, post-op treatment of ocular surface damage, post-cataract surgery includes your appropriate lubricant, anti-inflammatory, taking care of the drug toxicity, treating the meibomian gland dysfunction, and taking care of the egress of TFM. Thank you very much.